you use the term paradigm shift. Today we will try to understand if really we are facing a possible new paradigm shift in medicine. So I hope that what we will see today will be exactly in that direction. Thank you everybody to be here, even more today because it's so beautiful sunny day that there is something of heroic to stay inside of a room instead of walking down the streets of Dublin in a so beautiful day. Also in Italy, I know today they have 30 degrees, so it's almost summer. So we are brothers in this today. Before starting, as always, in order to create the right atmosphere, please stop me in every moment if you need to ask a question. Don't wait for the end of this seminar. And even more, since some of you are friends and already attended some seminars, it would be very beautiful if you will bring to the attention of all the other friends your experience speaking about physiological regulating medicine. Today, the focus will be, as you can see by the title, on the possibility of low-dose pharmacology in the field of acute chronic and autoimmune inflammatory diseases. This is what we have developed, especially in the last decade, and focusing our attention more and more in the possibility of the use of low-dose cytokines. So that will be especially what we will do. In terms of what we will do today in these more or less 4 or 5 hours we will spend together, is that since I know some of you are already experts in low-dose medicine and other maybe a little less, I will start, even though in a very synthetic, brief way, from the basis of low-dose pharmacology. This seminar is mainly based on methodology and pharmacology. My personal goal will be more than to give you some possible protocols, to put you in the condition to establish by yourself the possible protocol, since our medicine is a tailored medicine and every patient is different. So it's good to think in terms of protocols, but every protocol must be adapted to the specific patient. I will focus your attention on the action mechanism of low-dose signaling molecules. When I use the term signaling molecules, I mean neuropeptides, cytokines, today especially cytokines, hormones, and growth factors. So in order to understand how do they work, I will spend some time speaking of molecular biology and immunology for sure. This way we will be ready to understand the fundamentals of psychoneuroendocrine immunology, which is one of the roots, maybe the deepest root of physiological regulated medicine. We will speak about that. Since inflammation is the mother of all the diseases, we will spend the most part of time speaking of inflammation, looking at that by an immunological point of view and try to understand how some molecules, cytokines, can lead the mechanisms of inflammation. We have spent a lot of energies, both financial and intellectual, in research. Especially I like and love preclinical research because it allows us to understand the intimate mechanism of action of a molecule. And today I will bring to your attention the results of preclinical studies, both on cells and in animal model, and even more clinical trials. So I will bring to your attention some protocols related to the evidence from the research. And from research we will be at the end of this seminar in the position to really understand how to establish a good clinical application using this new pharmacology. So this is the big menu of today. I'm strongly convinced that the best way to learn is having fun. So I hope that we will enjoy and we will have fun today speaking about cytokines and immunology. I know that it is quite strange to have fun speaking of immunology, but it is possible, so we will try together to do that. And I want to start immediately in a very pragmatic way. Why so good doctors here in Dublin today are going to spend their day understanding low-dose pharmacology? And I try to write some reasons why makes sense to stay together here today. Why choose low-dose pharmacology? First of all, because according to our clinical trials, but also according to preclinical research, I can say, and I'm sure say that this type of pharmacology has 100% of clinical safety. You know that this is the starting point because primum non nocere, the Latin said. And with this pharmacology, you will understand deeply why we are in that position, 100% of clinical safety. Because it allows long-term treatments, another big issue. I want to involve you immediately. Please correct me. But I don't know any anti-inflammatory drug designed for the treatment of chronic inflammatory diseases. Tragically, we are used to think in terms of chronic use of, for instance, NSAIDs, which are designed for acute inflammatory disease. So, the question is, what can we do in order to ensure 100% of clinical safety, especially in long-term treatment? You will see in our studies, for instance, clinical study in patients with rheumatoid arthritis, that it is possible a long-term treatment without any side effect. Third, effectiveness. We can say that this is a beautiful pharmacology because 100% safe. But if we don't have the evidence of the efficacy and even more effectiveness, okay, it's good, but it's fresh water. You will see that according to the good clinical practice and good clinical research, it's absolutely effective. I will bring to your attention some of the most significant trials. Because it allows an overlapping approach. We use also in our language in Italy the term overlapping, and it is one of the terms that I like more in medicine because it doesn't exist the perfect pharmacology. Allopathy versus homeopathy. And the problem is that sometimes they approach these two medicines, allopathy or homeopathy, with an ideological thinking that is absolutely wrong in science. Because I'm sure you agree with me, in a patient with bronchopneumonia, absolutely you have to think first of antibiotics. But maybe in a kid with recurrent respiratory tract infections, could be interesting to overlap the treatment, antibiotics and low-dose treatment. So we have to love low-dose pharmacology, but always with a critical approach. So the best is an overlapping approach. 5, because low-dose pharmacology allows to fill the therapeutic vacuums in Latin, and I put also the S according to English. Because we cannot approach all the diseases with the conventional pharmacology. Just think of diseases like vitiligo, for instance, where doesn't exist a real gold standard therapy. They consider a gold standard therapy the microphototherapy UVB narrow band 311 nanometers. So, unless you use immunosuppressive, but you cannot use for long-term treatment. So, really, this is a new possibility, a new paradigm, in order to fill those gaps. And last but not least, it allows affordable costs. I mean, we did a study in our country, in Italy, 1 year treatment with biological drug, I mean monoclonal antibodies, for a patient with Crohn's disease costs to the community 18,000 euros. 18,000 euros. So every hospital can treat only a little number of patients, and the other, or you are a billionaire or you will live with your disease. Instead, there is a possibility to reduce the administration of a monoclonal antibody in order to keep low the disease activity using low dose medications, reducing the cost of the therapy. So once again, it's possible to match the two different pharmacological approaches, and this is what we will do today. In order to pharmacology in low dose medicine, today we will learn how to use the entire bag of tools of physiological regulated medicine. And we will study both single component based medicines, because we have the possibility to use a single cytokine, interleukin 10, or interleukin 4, or beta estradiol, or BDNF, brain-derived nervous factor. You are the first doctors in the world to see the results of our study on Alzheimer's in an animal model. So we will speak in terms of single medications, or very interesting, multi-component, multi-target based medicines. Because in order to use the concept of synergies and complementary, in some low-dose medication, you will have more than one active principle. All together will work like a team. Very interesting is that in the same multi-component medication, you will be able to identify both active principle from homeopathy, I don't know, arnica, belladonna, nux vomica, living together with cytokines or hormones or growth factors. This is absolutely something new and innovative in complementary alternative medicine. So, the perfect marriage between the homeopathic science, where medications work according to the two main principles of homeopathy: similarity and inversion of the effect, or if you prefer, hormesis. Living together with signaling molecules that, and this is the first thing I want to underline with you, that work not according to the homeopathic paradigm, similarity and inverting effect, but in terms of physiology. I mean, when you use interleukin 10, it will work not inverting its effect, but it will work in the only way which is a physiological way, which is related to a precise, very precise concentration. Another example to better understand the big difference between homeopathy and molecular biology-based substances. When you use Nux vomica, it means that if I give big quantity of Nux vomica to a healthy subject, because of the toxicity of strychnine inside of Nux vomica, I will provoke some particular and specific symptoms which are related to the toxic activity of Nux vomica. When I see a person with symptoms not related to an intoxication of Nux vomica, but similar to those ones, I will use the same substance, Nux vomica, but in a very low dose. Why? Because some substances, not all the substances, after the typical trend that is a linear curve dose effect, some of them are able to show a biphasal trend. In high concentration, they provoke symptoms. In low concentration, they are able to manage those symptoms. And we know exactly which are these inverting effects. In a very modern way now, they speak in terms of hormesis or hormetic effect. The father of hormesis is Professor Edward Calabrese, biochemistry of Massachusetts University. Okay, so Nux vomica works this way. Arsenicum album works this way. Cytokines hormones don't work this way. They don't invert their effect. By a clinical point of view, if you face a patient with hyperestrogenism, if you thought in terms of homeopathy, in order to cure that patient, you should use beta-estradiol in a very high homeopathic dilution in order to invert the effect. Doesn't work this way. If you are facing a hyperestrogenism, according to this paradigm, you will have to refer to physiology, which is the hormone able to induce the negative feedback on estrogens, progesterone. So you will refer in this way to physiology, to endocrinology, not to homeopathy and homeopathic effect. So in some medications you will find both substances, plants, minerals, animal derivatives, working according to this hormetic effect, and biological molecules working according to physiology. That's the reason why this medicine is called physiological regulating medicine. I think that I will fight all the day with this flip chart. Okay. No, maybe no. Okay, I will try not to exert all the energy. I am, those of you who are homeopaths, I am a paradigmatic subject of a specific constitution, phosphoric. Okay, I am the mage of phosphorism. That, in classical terms, doesn't mean anything. But if you study the constitutions by a PNEI point of view, I will be a subject with the kinetics of T3, T4 very, very high. I am a guy with hypocorticosurrenalism. That's the reason why phosphoric subject, after working, is completely done. But in order to maintain the homeostasis, since I have a constitutional hypocorticosurrenalism, I compensate that hypocorticosurrenalism with an hypermedullasurrenalism. I'm producing a lot of adrenaline, you can see, and you will see me for 6 hours. That's the problem of the flip chart, that it has to face an adrenalinic guy. So it's nice to study homeopathy by a new modern way, which is a psychoneuroendocrinology. This is an example of a multi-component medication in physiological regulating medicine. This is a multi-component for the treatment of inflammation. You can see, please look, that in the anti-inflammatory action core, you have both remedies like aconitum, napellus, belladonna, atropa belladonna, apis, ferrum phosphoricum, which are the typical, very well-known remedies for the management of specific phases of inflammation. For instance, aconitum in homeopathy is specific for the neurogenic phase of inflammation, the first one. Belladonna is specific for the vasal phase of inflammation, the second phase. Apis and ferrum phosphoricum are specific for the interstitial phase of inflammation. Why I'm saying that? Because if I take a healthy person and I give big quantity of ferrum phosphoricum, he will develop swelling tissues because of edema, because of exudative processes. According to the hormetic effect, very low dose of ferrum phosphoricum and apis will counteract the edema. But beside the typical homeopathic remedies working according to the homeopathic paradigm, we also have something from molecular biology. A monoclonal antibody in order to block interleukin-1, which is the trigger of inflammation. When you have an inflammation because of a trauma or an infection, your immune system reacts producing first interleukin-1. Interleukin-1 is involved in the onset of inflammation. So, if you will be able to block interleukin-1 with an antibody before the interleukin-1 will bind its specific transmembrane receptor, you will block the onset of inflammation. It contains interleukin-10, which is the most important anti-inflammatory medication that naturally we have in our body. It is involved in controlling chronic inflammatory processes. We have transforming growth factor 1, which is involved in the reparation phase of inflammation. TGF-beta is great because it is able to induce the deposition of collagen type 3 in the extracellular matrix. So when you have a wound, collagen type 3 deposits itself and you feel the wound. But it contains also melatonin. It's not an homeopathic substance, it's melatonin. Why melatonin in this medication? Because melatonin induces the vagotone, where inflammatory process is an expression of sympathetic tone. So we are able to recover the homeostasis. Beta endorphin, it works like an opioid, as you know very well. It is produced by pro-opiomelanocortin, and it is involved in controlling pain. Calor, dolor in Latin, pain, beta endorphin. It is something that we already have in our body, but when we have an inflammation, our beta endorphin, it's not enough. So we need to give from outside beta endorphin, or we need to sensitize the receptors for beta endorphin. We will see how we do that with the low physiological dose of these substances. So this is just an example to see which is the structure of these low dose medications. I'm very proud to show that in our department we also study the homeopathic remedies in a new way. I mean, we don't refer only to the homeopathic materia medica that you know very well. In the homeopathic materia medica, 60%, 70% of what is written is good. But, my friend, they have been written 200 years ago, when even the master Hahnemann didn't know about a lot of things. So is it possible to study homeopathy in a new way? Yes. Look just some example. You know aconitum. When do you use aconitum? For instance, during flu in order to control fever, right? Why? Because in the materia medica is written that if I give big quantity of aconitum to you, you will develop symptoms typical of aconitum. First of all, fever. But is it possible to study in a new way? Yes. Aconitum contains some alkaloids, hygenamine, aconitine, that's great, in low dose are able to downregulate NF-κB. NF-κB is the transcription factor that we have in our cell, NF-κB, and when activated by inflammatory processes, NF-κB enter inside of the nucleus, making DNA expressing for inflammatory mediators. Aconitum, in a modern way, works that way. So, if you downregulate the nuclear translocation of NF-κB, the cell will not produce more interleukin-1, the trigger of inflammation. TNF-alpha, which is upregulated in your patient with Crohn's disease, with rheumatoid arthritis. Interferon gamma, I mean, you will be downregulating the inflammatory processes. Atropa belladonna, another very important remedy that you know and you use in inflammation. It contains alkaloids, and this is nice. In low dose, those alkaloids in Atropa belladonna downregulate prostaglandin E2. In other terms, belladonna low dose, homeopathic belladonna, works similarly to corticosteroids. And belladonna enhances type 3 collagen synthesis, the same mechanism of TGF-beta we have seen before. Look, if you start studying homeopathy this way, you will understand even better why Hahnemann was a genius, because now we can analyze the alkaloids in aconitum. He couldn't, because 260 years ago it was not possible. But since he was a genius, he understood something. Now we are confirming the genial intuition of Hahnemann. Please.
I've been wondering, I try to express that properly. As I understand homeopathy in the dilutions or in the concentrations, it is given normally 30, 60, or
Yeah.
30, 60, or maybe 100. There would be no measurable amounts of the original substance, and would
Yeah.
as I understand what you're explaining, it would be the characteristic of the original plant or the original substance that would have a direct physiological effect. So how does that
Yeah.
work?
Okay. We can detect molecules in an homeopathic dilution when you are below the so-called Avogadro number, that in terms of concentration is D, you know the decimal dilution in homeopathy, D24, or you prefer in centesimal dilution, CH12. When you are below this homeopathic dilution, you can detect molecules. The highest concentration of molecule is in the mother tincture. When you dilute 1CH, 2CH, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, till 12 you have molecules. With which concentration? He is very, very high here, and more you go up, you have less molecules, less molecules, less molecules, no molecules. Don't forget that beside the dilution in homeopathy we use the dynamization, but we will speak later about it. So, when I say that when you use a low dose of aconitum, belladonna, arnica, you can observe this effect, I'm referring to this dilution. If you ask me, Alessandro, can you prove that using aconitum 200C, this is the mechanism? I can't. So that's the reason why. This is a very good question, thank you very much. In low-dose pharmacology, essentially, we use homeopathic dilution under the Avogadro number, below CH12, equivalent to D24. Yes?
Excuse me, but the Horvath's effect that you mentioned was actually studied with the higher potencies and higher dilution, so actually you can prove it.
Yes. In this case, you don't observe at this dilution the hormetic effect. For some substances, not all the substances, you observe the hormetic effect. For instance, Nux vomica. But in Arnica montana, you don't observe the hormetic effect. That's the reason why you use the mother tincture of Arnica montana, both in phytotherapy and in homeopathy. So, the hormetic effect is related to some of the homeopathic substances, and the most part over the Avogadro number. It depends by the toxicity. For very low toxic substance, you observe the hormetic effect even below the Avogadro number for some substances. For very toxic substances, just think of arsenicum or other substances, over the Avogadro number. When you use in low homeopathic dilution, you can refer the action mechanism also to this mechanism related to molecular biology. So it's interesting also to understand how they work, once again, when you are using them not in high homeopathic dilution, but in very low homeopathic dilution. And then, after this little premises, let's go focusing our attention to the real innovative part of this pharmacology, which is the possible use of signaling molecules. And I want to start provoking a question in your mind. Are we facing a pharmacological heresy? The heresy is that everybody studies that if you use a substance under the minimal pharmacological effective dose, you don't have any effect. I mean, if you use amoxicillin instead of 1 gram every 8 hours, 1 milligram every 8 hours, you don't observe a little less effect. You don't observe any effect because you are under the minimal effective dose. So you will see that when we use beta estradiol or interleukin 10 or serotonin, we will be using those substances in a concentration that is picograms, femtograms per milliliter, which is much less than the minimal effective pharmacological dose. These substances are sometimes used in allopathic pharmacology. I mean, we are not the only ones using hormones or cytokines, but which is the difference with the typical allopathic pharmacology? Is that they use them in nanograms, micrograms, which are concentrations over the minimal effective pharmacological dose. So, if you just think in terms of classical pharmacology, it would be an heresy. I will show you, according to our research, that it is not a pharmacological heresy. And also consider that neuropeptides, hormones, I told you, it will be a big battle. Neuropeptides, hormone growth factors, are in our body in physiological condition exactly in this dilution. I mean, I don't have grams of testosterone. I'm not depressed, but I don't have micrograms per milliliter of serotonin in my body. This is the physiological concentration of these substances. So in other terms, we try to reproduce in medications what Mother Nature does normally. So, will be an heresy? I can tell you no. And low-dose pharmacology, beside the use of natural substances according to the homeopathic paradigm, plants, animals, and minerals, focus especially on these substances. I mentioned them already several times today. They are called signaling molecules. Sometimes in literature you will find them as messenger molecules. That is nice because they bring a message to a cell, in other terms. And low-dose medicine starts from an idea that is, why not to use, under the form of medications, the same substances that normally lead the physiology of the body. And if you think, since the early 70s, all the physiology researchers and molecular biology focus their attention on those molecules. Also because they said that in physiological condition, I mean in healthy conditions, those substances lead the physiology because they are in this concentration. Picograms, femtograms per milliliter. If you don't remember the grade of picograms and femtograms, my friends, picograms is 10 to the minus 12, femtograms 10 to the minus 15 of a gram. I mean, it's very low dose. But our body works like an homeopathic machine. It doesn't need big quantity of these substances. And they discover something that is absolutely crucial for us, that if you have this concentration, you will be in a healthy conditions. But if you have an alteration of this concentration, but just for the signaling molecules, I'm not speaking about Nux vomica or arnica, too low or too high, that will be the picture of a disease. We will study a lot this concept. Now I'm just introducing them. That's the reason why, even us, we decide to focus already 25 years ago our attention on these substances. Was beautiful for us to discover in literature that in physiological conditions, these molecules are in an homeopathic dilution in our body. Because when I say picograms, femtograms per milliliter, I'm speaking in terms of a 4CH homeopathic dilution. That's the reason why, just joking, 2 minutes ago I said our body is an homeopathic machine. It's beautiful to find that really Hahnemann understood so well the physiology. Signaling molecules are, just to understand what are these substances. They are messengers, even better. The words used by the cell to talk each other and to understand each other. If cells will be able to communicate each other, you will be in homeostatic, healthy physiological condition. When two cells will be not more able to talk each other, that will be the onset of disease. So, why not to reestablish the right communication? In molecular biology, we say crosstalk between cells. In low-dose medicine, but not only in low-dose medicine, disease must be intended as a lack of communication between cells. I will show you literature about that. So please impress your mind with the concept that these medications now, which are actually biological molecules, are messengers, words. In other terms, now we know which is the dictionary, the vocabulary of the cells in our body. They don't speak English, I'm sorry for you. They don't speak Italian, they don't speak Chinese. They speak their own language, and their own language is only that. Cytokine, neuropeptides, hormones, growth factors. Diseases, as I already told you, can be considered as consequences of changed concentration of signaling molecules. Changed concentration. So, the first step we did when we approached this new pharmacological possibility was, if diseases are changed in up or down concentration, which is the physiological concentration of these molecules, and thanks God in 2011, this is the reference, they state which is the physiological concentration for these molecules. It is in a range between 10 to the minus 6 to 10 to the minus 15. You know that in nature it's not everything is precise. It's a range. For instance, hormones are present in physiological condition in a little higher concentration than cytokines or neuropeptides. Instead, cytokines and neuropeptides work physiologically in a concentration which is 10 to the minus 12 picograms, 10 to the minus 15 femtograms. Interesting. This is the concentration at the level of the extracellular matrix. Once again, if you like to translate this concentration, nanograms till femtograms and picograms, is 4CH. Just a look, okay, just a look to this table in order to synchronize all of us. What does picogram means and femtograms means? Okay, look, 0, 0, 0. I mean 11, 0 before 1. In pharmacology, we are used to think in terms of milligram the most part of times. So it's really a low dose, a very low dose. But please add the term physiological low dose, because low dose, if we are not precise, doesn't mean anything. Physiological low dose. And why a dose of a signaling molecule must be low? Everything is played on this structure, that is the transmembrane receptor of a cell. This is a very beautiful image. Now I will try to do something on the flip chart and it will be really terrible. So, okay, look what I do. This is a cell. This is the transmembrane receptor. This is the extracellular matrix. We will speak a lot about extracellular matrix. This is, okay, the red is even better. This is a blood capillary, and this is a lymphatic capillary. This is the direction. This is the direction. Thank you very much. Okay, what happened? When we release a cytokine or an hormone, we release that signaling molecules in the extracellular matrix. It has to pass through the ECM to arrive to the transmembrane receptor, binding the transmembrane receptor. In this moment, I'm only speaking about the transmembrane receptors. You know very well that also exist soluble receptors, cytoplasmatic receptors, cellular receptors, but what we have been able to investigate is only the action on the transmembrane receptor. Why it is so important, the concentration? I try to be very synthetic in this time. If you give a concentration of signaling molecules that instead of to be the physiological one is too little, you easily understand that it is too little that is not able to excite the transmembrane receptor. If you give a concentration which is not the physiological one but is an hyperconcentration, you observe that phenomenon that in molecular biology is called downregulation of the transmembrane receptors. In order to protect itself, the cell closes the transmembrane receptors. But closing the transmembrane receptors, he doesn't have more the instruction to work. Just think if this is a fat cell and this is beta estradiol. One of the functions of beta estradiol is that one to be liposynthetic. If it doesn't arrive to the cell because the receptors are closed, the cell, instead of to be hypertrophic because of the message of beta estradiol is liposynthesis. Liposynthesis will be down. But you can imagine the same for all the other signaling molecules. Instead, if you provide a very precise low dose, which is the physiological one, so we didn't decide which one, Mother Nature did. That is picograms, femtograms for hormones, nanograms, you induce the so-called upregulation of transmembrane receptors. It means that giving that concentration, all the transmembrane receptors will be sensitive and ready to bind the molecule. In other terms, using these medications, you make the cell in the position to be very sensitive to the molecules that your body naturally produces. Upregulation with a physiological low dose. Downregulation with a very too high concentration. Sometimes I use the example of two cells talking each other. In other seminars, maybe also here in Dublin I did it. If we anthropomorphize cells, two cells wants to speak each other. It's just to understand up and down regulation of transmembrane receptor. For instance, this is a cell of the central nervous system. This is a cell of the endocrine system. Here we have the extracellular matrix. This is an hormone. This is the receptor. Through the ether, the beta estradiol has to travel in order to arrive to the transmembrane receptor of the central nervous system cell. But if I am a man and you are a woman, and I use my language, words, I told you signaling molecules are words, and I use the word, hey, I love you, it's not only important the quality of the message, I love you, but also the volume of the message. Please translate volume in concentration. So if I say I love you with this voice, you cell understand. Your transmembrane receptors, your ears, will be excited. If I use too little of the message is correct, but it is too little, not able to stimulate your tympan, you say tympan, membrane. Perfect, it is a receptor. On the other side, if I use the right message, yelling on you, I love you like a crazy, which will be your reaction, that you will protect yourself. Very, very often when I do this little example, a doctor, normally a woman, because I do this example, close her ears. That's perfect. That's a downregulation of transmembrane receptors. Just to have fun. Also, between cells exist stalkers. And which is the reaction of a woman when someone stalks her? Go to the police. The same for the cell. Only if you are nice using these substances, you will be effective. I like this little sentence. This is the medicine that whispers to the cells, not yell on the cells. Okay, so please remember why you decided, you found this concentration. Actually, is the natural concentration for these substances in physiology. How low must a low dose be to be effective? Okay, I already told you. I already told you we are in this range of concentration under the minimal effective pharmacological dose. but we have not been the first ones thinking to use cytokines. Also, the classical pharmaceuticals try to use cytokines, but since they use them in high concentration, they had beautiful pharmacological effects, but very severe side effects. Since we come from homeopathy, we were used to think in terms of low dose. So we try to go below the minimal effective pharmacological dose. And we observe something. First, look, according to literature, going below, you are in the physiological range. And we discover something that our master, Hahnemann, would have been very, very happy to see. That if you don't dynamize that low dose, you don't have any biological effect. Instead, if you use a very low dose and you dynamized that low dose, it works exactly as well as the pharmacological concentration, but without side effects. In our department, we call dynamization, you know what is dynamization, no? The succussion, okay? Invented by Hahnemann. We call it sequential kinetic activation. Why we use this term? Because when you try to publish in an indexed and impact magazine, in PubMed, and you use terms like homeopathy, dilution, dynamization, succussion, even though your study is the most beautiful in the history of research, never will be published. So, at the beginning of our publications, we decide, okay, let's go saying the same using another terms. Sequential, because every passage of dilution we dynamize. Kinetic, why kinetic? The movement. Activation. And I explain this concept in terms of it is a drug delivery system able to make molecular concentration effective even below the minimal effective dose. Look that for all of us who love homeopathy, it's interesting that in 2012, Bulletin of Experimental Biology and Medicine for the first time wrote that the active substance is able to release its activity in the water milieu. For the first time, something not related to homeopathy said, look, that you have to investigate water, because water can become a drug delivery system. Delivering what? We know, an electromagnetical information. And it is so interesting, my friend, to know that what happened at the level of the transmembrane receptor when a ligand binds the transmembrane receptor is not what we studied. They explained to me the mechanism of hormone and receptor, neuropeptide and receptor, in terms of key in the lock. In the lock, I'm right?
Yeah.
It's not true. Because now we know that what happens when a ligand binds a transmembrane receptor is not the contact of the ligand with the internal wall of the transmembrane receptor. But every ligand is able to establish a type of chemical bindings that is very, very weak. Van der Waals forces and hydrogen bridges. Which is that molecule able to establish that type of bindings? Water. So very possibly is the water activated by the dynamization which stimulate not touching the internal wall of the receptor, that means the cell. That has to be much more investigated, but can be a possibility to understand why you dynamize, you see an effect. You don't dynamize, you don't see the effect. Since it's beautiful to speak only according to references, I show the first study. Animan would be very, very happy to see this. Of a study performed by the University of Milan, Department of Human Morphology. Effect of different doses of interleukin-1 beta on isolated human fibroblast. Don't be afraid for this slide. I will try to explain, and it is the praise to understand the results that I show you immediately. Okay, look, this is a cell. This is the cell membrane. Here, in light blue, we have the cytoplasm. Please look, this is the specific receptor for interleukin-1 beta. I already told you, interleukin-1 is the trigger of inflammation. When interleukin-1 binds its receptor, that's the signal for a cascade of other signaling pathways inside of the cell that lead to the activation of NFKB that we already studied. NFKB is a transcriptional factor able to go inside of the nucleus, activating some DNA sites for the expression of inflammatory mediators. This is what happens when we have the onset of an inflammation. Good. So, in molecular biology, you measure NFKB to understand which is the effectiveness of interleukin-1. Look at the results, which are really impressive. Expression of NFKB on isolated fibroblasts. These are Western blottings. This is the quantity of NFK beta, the Kb produced by the fibroblast when you give the fibroblast lipopolysaccharides. This is the active control. NFKB after administration of placebo, water and alcohol. You can see that there is an expression of an FKB which is due to the alcohol. Why we tried alcohol and water? Because the medications are in hydroalcoholic solution. And now the most important part. B, this is great. B is the quantity of an FKB expressed by the fibroblast, giving the fibroblast for 6 hours. It will be this way. Okay. You know what? I do this and stop. Giving the fibroblast an allopathic concentration of interleukin-1 beta, micrograms per milliliter. You see that the cell reacts a lot, but 18 hours. At 24 hours, the cell went in apoptosis. Side effect. It's a cell side effect. What is C? C is the quantity of an FKB produced by the fibroblast after contact with a low concentration, femtograms of interleukin-1 beta. If even for Western blottings existed standard deviations, C and B would be the same. I'm meaning that femtograms and micrograms show the same effect. But, and I want to write but, big, but only if you give femtograms dynamized. If you give femtograms not dynamized, look, water, fresh water, nothing. So honestly, I don't know exactly what happens when we shake, we succuss, we dynamite. But this is the evidence that something happened. A very famous professor of urology of the George Washington University, friend of mine, one time told me, "Hey Alessandro, I don't care of what happened before when you activate or not activate. This is the evidence that something happened and the biological effect is completely different." So it's important, just to finish this part of our seminar, it's important to use low doses, which are not whatever low dose, but a physiological low dose. And when I say physiological, I mean picograms, femtograms, and they must be activated according to the dynamization concept of the father of homeopathy, who is Hahnemann. That's the reason why every morning when I get up, I say thanks, Christian Samuel Frederick, because if he didn't exist, we wouldn't be here today. Never forget Hahnemann and Reckeweg, two giants of medicine. Now it's beautiful to demonstrate that they were right, even though they didn't have almost any instrument. What is beautiful, my friends, is that about low-dose medicine, we are not the only ones in the world speaking of. This is just one of the reference, but I have hundreds of these. This is BMJ, and look, a rapid induction of clinical remission by low-dose interleukin-2 in a patient with refractory lupus erythematosus systemicus. Low dose. I mean, all the medical environment, especially pharmacological environment, is going towards the direction of no more so big quantity of active principles, but low dose. They performed this study not with our low dose, but it's beautiful because from different countries, from different parts, we are arriving to the same target. I have to say that apart us, interleukin, low dose, interleukin-2 is the most studied interleukin. It's a very interesting interleukin. We will speak about that in the afternoon, speaking about age-related immune deficiencies. When you have an elderly patient and old grandfather and you want to stimulate the immune system, this is the best interleukin ever, and you will see why, obviously. Okay, good. So after this premise, I try again. I think that it's not only because I am phosphoric. Even with a carbonic speaker would be the same. You know.
Do you want us to replace it now? Because we can get the new.
Why not? I
okay.
keep on speaking, and when
okay.
they are ready,
Yeah,
it's okay. But maybe it will be the same because I know myself. I'm always a little exaggerated when I speak. But you know, when you touch with your hands the beauty of these concepts, of this pharmacology, the enthusiasm will capture you. Okay, good. Let's go open another section of our seminar. Principle number 1 of low-dose medicine. I told you, this time here in Dublin, we decided to be very methodological, because it's important to understand the basis of this medicine, and it will be very rational and easy to apply to the different needs you have. Okay, first, every disease is a systemic disease. I want to imprint you today with this first concept. Absolutely central in low-dose medicine. Just to provoke you, osteoporosis is a disease that involves which tissue? Bones. So can we say that, I'm provoking you, it's just to stay a little upregulated, exactly. Is it right that osteoporosis is a disease which involves bone? Yes, but no. It's a systemic disease. Yes, obviously, it involves the bone, but the bone is only the last part of the pathway. Why we observe osteoporosis, especially in menopause? Because lack of estrogens makes parathyroid glands producing too much of parathormone, and parathormone alterates the salt's homeostasis, provoking acidosis, and acidosis provoke inflammation, and inflammation stimulate osteoclast and inhibit osteoblast. So, if we don't have this picture of systemic disease, we immediately will go to treat the bone. No, you have to treat first ovaries, okay? So, it's a different concept. But if you stop for a second and you think to other diseases this way, I think that for the most part of diseases, you will agree with me. So, systemic disease, please, this is important. To understand this concept, we need to spend some words. Okay? Okay, so we are highlighting the concept of every disease is a systemic disease. To understand that, I like to refer to the paradigm of psycho-neuro-endocrine immunology. Look, that this is really something beautiful. Since I am in love with classical homeopathy, homotoxicology, I think that the PNEI paradigm is the better actualization of the concept of globality of homeopathy. In other terms, we are mind and body. Hahnemann understood that 260 years ago, I mean. Please look that the central nervous system and the autonomic system, the endocrine system and the immune system, it's not casual that they are called homeostatic control systems. I mean, they control our physiology. In order to understand in a synthetic way, but in an effective way, I hope, the PNEI paradigm, I'm used to refer this to two concepts that will be continuously present today during this seminar. The first concept is typical in physiology, and it is the concept of homeostasis. Homeostasis, balance, equilibrium, I don't know what, which is the capability of the body to maintain in a precise range of values the vital parameters. For instance, glycemia, more or less, between 60 and 100, 110 milligrams per deciliter. Oxygenation, the saturation of the blood, more or less 90–80%. pH, we spoke about osteoporosis 2 minutes ago. How much important is pH in controlling physiology? I mean homeostasis, I mean health. If pH is lower than 7, acidosis, is higher than 7.5, alkalosis. Temperature, 36, 37 Celsius degrees,
Okay, otherwise hypothermia or fever. Why this slide is very nice? Because it relates PNEI systems and vital parameters. With conventional allopathic pharmacology, we have wonderful tools to act primarily and directly to the alteration of the vital parameter. But who is controlling and leading the values of the vital parameters? The three main homeostatic control systems. I mean, they are something like the big brother of our body, controlling our functions. So if you have an alteration in the pH, heat exists because something happened before here. So, since they are the controller of the homeostasis, would be beautiful to have the possibility to talk to the immune system, saying to the immune system, hey, take it easy if temperature is here. Or telling the immune system, hey, wake up. The same to the central nervous system, the same to the endocrine system. I mean, if we will be able to control the controllers of the homeostasis, we will be able to recover physiology. Yes, beautiful, Alessandro, but how can talk to the immune system? How can I talk to the endocrine system? You can, because you have the words that can be understood by the immune system cells. Those words are cytokines. You have the words that can be understood by the endocrine system cells. Those words are hormones. Those words are neuropeptides. And you also have those words in the right volume. You remember, I love you or I love you. So you have exactly the tools in order to recover the homeostasis according to physiology. So, PNI, homeostasis. The second concept, and we are going to see something really interesting. The second concept, in order to understand the PNEI paradigm, is the concept of the bidirectional crosstalk. Bidirectional crosstalk, look at these arrows, that we can observe both between systems and inside of systems between cells. That's the reason why in low-dose medicine always is important to consider both the psychosomatic direction and the somatopsychic direction of a disease. Everybody knows that stress is related to gastric ulcer, or is related also to immune deficiency in cancer patients. But we have also to consider this direction. Just think of this direction. Endocrine system, central nervous system. Why that woman, Mrs. Smith, that for 54 years has been the most sympathetic, funny woman, now she's a little depressed, or if not depressed, with mood instability. If you don't have the concept of systemic disease, you will look at this one. That's the reason why the solution will be to provide through serotoninergic drugs, serotonin. But if you look at the disease as systemic, and you think 54 years before, no problem. Now something happened here. If you don't recover the balance on this system, you will be obliged to give and give and give continuously the serotoninergic drugs. So important always to investigate both the psychosomatic, somatopsychic direction, and now I think is even more important to think in terms of circularity in the etiopathogenesis of the disease, which is the maximum expression of the concept of every disease is a systemic disease. So, systems talk to each other. Even cells talk to each other. Do you know this guy will be an award for, you studied him, eh? This is Virchow, the father of the cell theory. Is the guy who said everything everything is in the cell. He is the guy who make us understanding the importance of the cell. And he's a great scientist. But he did a mistake because he didn't consider that every cell is in communication and related to another cell. Virchow. Is written
Virchow.
Oh, is it correct? Right? Okay. So, since for us it's very important the concept of systemic disease, we don't have to look at one cell, but we have to look always at the system of cells. This is nice because if you anthropomorphize cells, they are like us. Sometimes we are convinced to be the only ones in the universe. No, maybe someone else is providing a seminar, is holding a seminar, I don't know where, in the universe. So, what I ask you is to pass from the concept of cell and from the cell theory to the system theory. We have in our body 40,000 billion cells. 40,000 billion cells. This is the reference. Someone crazy counted them, I think through some algorithms. Is in Italian, in fact, Bianconi, and published on Annals of Human Biology in 2013, saying, look, that we are 40,000 billion cells. And all these cells talk to each other. I mean, it's important to look at them as a systems. Sometimes, speaking about these, I'm used to say, to ask the attendees, which is the biggest social network you know and you use? You are young. Which is the social network you use? Facebook. Be careful because now. Okay. How many people use Facebook? 2 billion in the world. It's nothing. The biggest network is inside of your body. 40,000 billion cells continuously send messages through the ether, where the ether is the extracellular matrix. Those emails are not emails, are hormones, cytokines, neuropeptides. It's beautiful to look at our body this way. And what happens when for 30 seconds in a room you don't have signal in your iPhone? Panic! My God, I am isolated. I am not in communication with the others. Look, that the same happens to the cells. If a cell doesn't have signaling molecules, it will die because it will not have more instructions, cytokines, hormones, for its biological function. he will not have more nutrients, and it will go in apoptosis. So it's important to reestablish, like technicians, this communication between cells. So it's, I have a lot of this. But even more important is what scientific magazines write about that. This is autoimmunity reviews.
Alessandro, sorry, could you just...
Is nice.
Very nice.
Look, that the best way, I mean, I have spent and still spend my life 24 hours studying this, no? If you don't look at the cells like humans, after 2 hours you take a gun and you shot yourself because it's the most boring thing. Instead, if you anthropomorphize cells, they have a soul, they are in love with each other, they talk each other, they have fun each other, they send emails. It's easier to understand what they do, and it's also much, much fun. Okay, I will, in 5 minutes, I will show you a video from nature. I cried when I saw it, because I said that I was not crazy thinking that. Look, okay, but literature, you know, in our field, you exist if you publish. Autoimmunity reviews, in French, conversation galante, okay, nice conversation. How the neuroendocrine systems talk to each other. This is something that is mainstream now. Okay, look. This is unbelievable. Raised plasma NGF, nerve growth factor levels, associated with early stage romantic love. I mean, all the cells are in communication with each other, and they are in communication with the system, with the environment, with the other people. This is great. NGF is the nerve growth factor discovered by an Italian scientist, Rita Levi-Montalcini. She won the Nobel Prize. NGF is the nervous growth factor which keep young your brain, feeds your brain. So what they say, if you are in love, you produce NGF and you will become old later. Unbelievable. It's important to be in love. Yeah, Alessandro, you are romantic. No, I'm not romantic. I'm referring to a very scientific thing. So, the good news is that to be in love is important for our health. The bad news is in the title. Early stage romantic love. It means that after 3 months you met your wife, you are not more producing NGF. But I think that is important every day to find a way to be in love with your husband. Otherwise you don't produce NGF. Okay? If you are going to divorce, you can take this paper to the judge if something happened because of the divorce. I don't know if we'll accept or not. Interesting. Neuroimmunocutaneous endocrine network. Relationship between mind and skin. Come on. Dermatology is not something for dermatologists, but is a specialty for internal medicine doctors, because really skin is the mirror of all the systems. What did they do? 2003, dermatologic therapy is unbelievable. I like this paper. Even more, International Journal of Dermatology. Look how old could be thinking not in terms of systems, but just in terms of cell or tissue. Can the brain inhibit inflammation generated in the skin, the lesson of alpha melanocyte stimulating hormone. This is really crazy. The brain can inhibit inflammation in the skin. What did they do? They injected alpha MSH that I studied as the hormone able to stimulate a melanocyte to produce melanin, alpha melanocyte stimulating hormone. That one is just one thing that MSH does. If you inject in the brain ventriculi and you have any interruption in the spine, in a millisecond, you will cancel the inflammation, provoking the skin experimentally with capsaicin. Look that 20 years ago, it was crazy to think this way. You are injecting an hormone in the brain, and in the skin disappears the inflammation. Are we a system? Oh yes. Is the brain tightly connected to the skin? Yes. So always we need absolutely to think in terms of systems. Vitiligo, we publish a lot on vitiligo, and vitiligo is a very interesting example we will see during this seminar as a systemic disease. Melanocytes don't produce more melanin because keratinocytes are not providing them the right messages. And keratinocytes are not more providing them the right messages because they are in apoptosis, because there is a very strong inflammation. And there is a very strong inflammation because a lot of reactive oxygen species. So if you look only at the cell melanocyte, you will be wrong. You need to think in terms of PNEI disorder. We will see that. And since we are speaking about systems, you already know that in our body we have 40,000 billion cells. And when we were convinced to have understood the human body, someone a couple of years ago, not so many years ago, came and said, look, that you are wrong. If you think only about the cells in your body, because in that case you are thinking in terms of organism. Now you have to think in terms of superorganism. The first time I thought, you mean in terms of Superman? Superorganism. No. Because not only the 40,000 billion cells talk to each other and are related to each other, but they are related to something that you, doctor, said during the introduction. They are related to the microbiota. I mean, the bacteria we have in our body. These are the numbers. For every cell of our body, we have 2.7 bacteria. Do you think you control bacteria, or bacteria are controlling you? I don't want to scare you, but believe me, bacteria control your physiology. There is an axis, gut-brain axis, and bacteria, through this axis, control your mood and behavior. This is what happens in autistic spectrum disorders patients. There is a very severe dysbiosis with a prevalence of Candida and Aspergillus niger, and that disruption in the homeostasis makes the central nervous system producing less oxytocin. Less oxytocin, no social behavior. That's a cause of ASD. But interesting, so they control you. Just some numbers. We have 2.6 kilograms of bacteria in our body, 1.5 kilograms in the gut. Cells and bacteria, they form the so-called microbiome. So the bacteria are microbiota. Bacteria and cells, microbiome. And they talk each other. So my friends, just to make even more complicated, don't think only in terms of psychosomatic, somatopsychic, but also you have to consider the bacteria, and especially the bacteria in the gut. In fact, my first take home will be take care of your gut. You like this, so I think that you will like a lot this. The gut calling the brain. And they call each other. It's absolutely important to consider what is the role played by the gut and by the microbiota in the gut. Why? The topic of today, I'm creating the premises, is inflammation, you know. Look, in the gut, we have a precise asset of bacteria. We have more, just an example. This is interesting, absolutely interesting. We have thousands of different species of bacteria. And even for bacteria of the gut microbiota, they live in homeostasis. I mean, the homeostasis is because both pathogens and commensal live in peace with each other. If you destroy this homeostasis between pathogens and commensal, for instance, stress is able, running along the gut-brain axis, to change the homeostasis of the gut microbiota. Food is able to destroy gut microbiota. Persistent long-term antibiotic treatment or autoimmune mechanism can change the homeostasis. If you change the homeostasis, instead of to have a little physiological control inflammation using the words of Collins and Bersick, you will not have more than immunotolerance. What do they say? What did they say? They said, look, that you need a little inflammation in the gut mucosa, because thanks to that little inflammation, you have immunotolerance. If you change this homeostasis, pathogens go up, and instead of immunotolerance, you will have pathological inflammation. You understand? They say, look, that in the gut microbiota don't exist good bacteria or bad bacteria. You mentioned the HP, the Helicobacter pylori. Is it good or bad? Neither good nor bad. If you have overexpressed gastroduodenitis and carcinoma, but you need, all of you need Helicobacter pylori in your gut. In 2013, Pediatrics, the American journal, the Journal of the American Association of Pediatricians, titled, "Are we building," this is unbelievable, "are we building a generation of obese kids?" Why? I went to read it. They were discussing if it was opportune to use the triple antibiotic therapy in order to eradicate HP in kids below 3 years. Thanks God, they said, it's not opportune. But which is the link between HP and obesity? Look, leptin, ghrelin, they are two more or less hormones, not exactly and completely hormones, but very similar to hormones. They control, together with insulin, glycemia, appetite at the level of hypothalamus. In which way? Leptin stimulates the center of satiety in the hypothalamus. Ghrelin, exactly the opposite, stimulate center of appetite in the hypothalamus. And they are related each other. Ghrelin, look, this is the passage. Ghrelin must go down after meal. Physiologically, it happens. Otherwise, you would be always almost a fracture of the metatarsus. All right. So, ghrelin must go down, and it happens to all of you, I hope, after meal. So you don't have this continue pushing the center of appetite. Do you know who is the biggest control of ghrelin, making it going down after meal? HP. If you clean HP from the microbiota, ghrelin will stay always upregulated, stimulating the center of appetite, and you will have a kid continuously going to McDonald's. Look that if you live sometimes in the United States, it's dramatic. The proportion of overweight and obesity, and is becoming a national emergency. So, interesting to keep and maintain.
Here in Ireland as well.
Yes, but much less. Also in Italy, there is an increasing trend. But when you land in some airports like Atlanta, the skinniest one is 100 kilos. It's really, and you will see today what a adipose cell contains. It is a bomb of pro-inflammatory cytokines. So you have a dramatic increase of cardiovascular diseases, Alzheimer's, and so on. So it's really so important this. So if you have a homeostasis, both pathogens and comments, so good. If you destroy through food, GMO for instance, stress, gut-brain axis, drugs, antibiotics. Look, thanks God we have antibiotics. I'm speaking about a not opportune antibiotic drug or autoimmune mechanism. You change, and this is the important passage, you change the homeostasis, you downregulate commensal, you increase pathogens, and you have the onset of inflammation at the gut mucosa level. I mean, bacteria control inflammation. Just to understand if it's true or not, Journal of Organic Systems, 2013. These are 4 stomachs from pigs. This stomach is from a pig fed with organic food. Little quantity of GMO, medium quantity of GMO, high quantity of GMO. Do you see any difference? My God, look the inflammation in this stomach. They are pigs, but pigs are the most similar to us, and so these are our stomach. And why we have this inflammation? Because that food destroyed the homeostasis of the gut microbiota, making a prevalence of pathogens inducing inflammation. So instead of to have the good immunotolerance due to a physiological inflammation, now we have a pathological inflammation. And if we have a pathological inflammation, we destroyed the junctional systems between the epithelial cells of the gut mucosa. I mean, this is the gut. These are epithelial cells, and this is the lumen. Here we have all the bacteria of the gut microbiota. Pathogens go up, inflammation. Inflammation destroyed the junctional systems, especially tight junctions, gap junctions, desmosomes, especially tight junctions, which are the most important because they are the most superficial one. They are here, very close to the lumen. And you lose the barrier function of the gut mucosa. So no more tolerance. Every bacteria, every food will be a pro-inflammatory substance at the level of the lamina propria below the monolayer. That's what happens, for instance, in Crohn's disease. Alteration of the microbiota, especially in Crohn's disease, we have an overexpression of adherent invasive Escherichia coli. TNF-alpha, the cytokine, very pro-inflammatory, able to break the junctional system, and you have a continuous inflammation at the level of the lamina propria. If you don't control the microbiota, you will have a problem. Maybe some of you are thinking, okay, Alessandro, you convinced me, and it is something related to gut diseases. Please consider that the gut, the centrality of the gut in our body, not only by an anatomical point of view. Consider the gut like those airports which are hubs for many flights. This is another beautiful slide that shows that if you lose the barrier effect at the level of the epithelial monolayer of the gut mucosa, you will have an increase of Alzheimer's. I will show you in the afternoon our paper. Anxiety. Why? This is a word of nuts. Nuts, you say nuts? Yeah, first of all, because we eat in a crazy way. Gut brain, gut skin, autism, I told you, depression, Parkinson's. So, I mean, it's absolutely important. If we have the concept of every disease is a systemic disease, first of all, start taking care of your gut. This is the first brick I want to put in the wall of our system, of our low-dose medicine system. What can we do to take care of our gut? Okay, something pragmatic after this methodological scientific introduction. It's very interesting, food supplements that is a combination of bovine colostrum and a plant, a Polynesian plant named noni. The botanical name is Morinda citrifolia. Now I show you why this is a very interesting, but really super interesting food supplement. The question is always the same. It is more important to kill bacteria, to introduce bacteria. So kill bacteria, antibiotics like HP. To introduce bacteria, you know that, I don't know in your country, in Italy, everybody gives probiotics. Okay, good. But we have almost 10,000 different type of bacteria in our microbiota. If you use a probiotics, maybe you will give 5, 6 strains. Are you really so sure that you will change the homeostasis in the right way? I don't know, honestly. I'm suspending every judgment. Okay? Why don't to work on a new concept that is select the microbiota? Because if you select the microbiota, controlling the pathogens and stimulating the commensal bifidobacteria and lactobacilla, you will be able to make that little inflammation that you need in your gut mucosa to have an immunotolerance working well. Instead, if you kill or you put, you increase. And you will have no more the physiological inflammation, but the pathological inflammation. Why it's so important, the colostrum? We have been fed by our mother with colostrum. It is called the first vaccination of the human species baby. It's considered the most complete food on the planet. Mother Nature is perfect. In this slide, I wanted to highlight just some component of colostrum. Look, IgA, IgM, IgG. So it's full of antibodies to protect the little kid that when is born doesn't have a very good cell-mediated immune response through Th1. So our mother, the first thing she does is, okay, I love you so much that I give you my antibodies. And they pass through milk and through placenta. It contains lactoferrin. Lactoferrin is a beautiful protein able to take out iron from the bacteria. Without iron, bacteria is like, it is full of interleukin 10. You will learn today that interleukin 10 is the most powerful anti-inflammatory cytokine that naturally we have. So it is immunostimulating food and anti-inflammatory food. It contains growth factors, insulin growth factor, epidermal growth factor, fibroblast growth factor, transforming growth factor. It is full of vitamins with antioxidant activity and minerals. I mean, it's really complete and perfect. Our study, published on Minerva Gastroenterologica and Dietologica, is an Italian magazine with a little impact factor, around 1, if I'm not wrong, published a study performed once again by the Department of Anatomy and Human Morphology in Italy, in Milan. Colostrum administration effects on epithelial cells turnover. For those of you used to work on this type of cells, they were CACO2 cells, carcinoma colon 2 cells, which is the typical cellular line used for this type of studies. Inflammatory events and integrity, especially you will see integrity of intestinal mucosa junctional systems. So, I told you it's more important to kill bacteria, to insert bacteria, or to select bacteria? To select bacteria. How can we induce a physiological selection of bacteria using a natural food like colostrum? Okay, we discover that colostrum is able to stimulate the human immune system to produce interleukin 8. Interleukin 8 is the interleukin we have in our body able to induce the recruitment of neutrophiles in the gut lumen. More neutrophiles, you know that neutrophils select bacteria, pathogens, so you will downregulate in a natural way through your interleukin 8, you will select downregulating pathogens and upregulating commensals. You can see which is the difference between the control cell line and using colostrum noni. You can see that with colostrum noni, interleukin 8 increases 25 folds. That is sufficient to induce a perfect physiological immune response. Okay, other references about how microbiota can lead inflammations. So, if you control the microbiota, you will be controlling inflammation. If you control inflammation, you don't destroy the junctional systems, integrity of the epithelial monolayer, that's fine.
Can I ask a question?
Right.
People ask who have cow's milk allergy, can they take colostrum?
Okay. Very interesting question. We have to make distinct two possibilities. If your patient has a real milk intolerance, I mean he has a lack of beta-galactosidases, the enzymes which hydrolyze lactose. Lactose is built by a molecule of glucose and a molecule of galactose. In order to free the glucose, you need to have beta-galactosidases, that enzymes. Well, if you have that patient without beta-galactosidases, you cannot give him colostrum, okay? Because it doesn't have the enzyme. And he will have a real symptoms of milk intolerance. I'm speaking about intolerance to the sugar. It is quite rare as disease, and normally it is diagnosed during the first 10 days after delivery, because the kid doesn't grow. The most part of those ones which are called milk and milk derivative intolerances are not due to glucose, not due to the sugar, excuse me, but to the proteins of milk. And the profile of proteins of milk is completely different than the profile of proteins of colostrum. So, in those patients that say, I am intolerant to milk, cheese, and something else, you need to give colostrum, because you will restore the integrity of the mucosa that, because of that condition, is quite inflamed. So we need to distinguish intolerance for lactose, intolerance for milk proteins. Did I answer you?
Well, in an idealistic way you did, but that's not actually what you get presented with. Like a colicky child, a colicky baby, there isn't a ready test to see if they're
normally the agalactosidasis disease is diagnosed in the first days, so it's quite difficult that someone doesn't know to have this deficit of beta-galactosidasis. 99%, maybe 99.9% are intolerant to the proteins, so you don't have a problem in
as if you have a more efficient medical system initially.
No, come on,
That's
the
not our
Anglo-Saxon
medical
medical system is good, so
But I
anyway, it's quite rare, the intolerance to
to lactose.
And I understand from what you said that this diagnosis is clinical because you
It's
can
clinical, yeah.
actually
Or-
have diarrhea and the child is not gaining, so you have in 10 days you have the direct symptoms and quite acute symptoms.
And also,
when
you know why?
beta-lactase
Because the
is-
kid doesn't gain weight. So
Yeah.
the pediatrician,
It's very concerned.
differential diagnosis, arrive to, okay, maybe is that. And blood test, and you see if he has a deficit of beta-galactosidase. But it's quite rare. So I think that in your daily practice, you face more intolerance for the protein. In that case, it is interesting colostrum. Yeah.
But you still can have intolerance of colostrum anyway, at times, yes?
Intolerance for colostrum,
Itself.
but it's quite
May happen.
it's quite difficult because the proteins of colostrum are not immunogenic as well as the proteins of full milk. Why? This is more phylogenetic. Mother Nature couldn't think of the first food of the baby of the species has something dangerous or able to provoke a disease, because otherwise the species could extinguish. So Mother Nature thought to a protein profile which is very little immunogenic. So that's the only explanation we have in order to do that. Sometimes during seminars, attendees ask me, yes, Alessandro, but that is bovine colostrum, which is different than human colostrum. Okay, but no one can produce colostrum, human colostrum, because you cannot take, oh, excuse me, ladies, madam, I take for my production in the factory. So the bovine is the most similar. Look at this data about the integrity of the intestinal mucosa through colostrum. Always thanks to lactoferrin, oligopolysaccharides especially, and even more, the growth factor, we have this data. Look, this is really impressive. This is the turnover of the epithelial cells in the cell line in starvation. I mean, without the culture broth. Okay. This is with, I don't know, brodo di coltura in English. When you cultivate the cells, you need to put in the capsule the culture broth. Okay, good. With only culture broth, only adding colostrum and Morinda citrifolia, noni juice. Look, I mean, you stimulate almost the double the turnover of the epithelial cells. It means that you stimulate the migration of the epithelial cells to become mature. Interesting. Please don't think, oh my God, I'm stimulating the differentiation of cells. No differentiation. Migration of the epithelial cells. So, giving colostrum and noni, you will see the gut mucosa that, insulted by food, drugs, stress, is inflamed and full of little wounds, again with the integrity restored. So, since from the gut we have the spreading of pro-inflammatory cytokines affecting all the other organs, please forget everything I have said till now, but don't forget to protect the gut mucosa in order to counteract the inflammatory processes
that from the gut mucosa spread out all over the body. Restores colostrum and noni the correct composition of the intestinal microbiota and the physiological turnover of the epithelial cells. If I had the possibility to look inside of your stomach mucosa or gut mucosa, oh my God, it will be inflamed and full of wounds. Colostrum and noni is like a microsurgeon that goes inside and restores that integrity. So we use it in leaky gut syndrome. You understand very well why. Atrophic gastritis and peptic ulcer. 40% of Italians suffer for IBS. We use it in inflammatory bowel diseases, you will see, together with other cytokines. Obviously in dysbiosis, because select the microbiota. Gluten sensitivity. I don't know in Ireland, but in Italy and even more in the States, gluten sensitivity is the epidemia.
Here as well, celiac disease.
Yeah, thanks God, gluten sensitivity in the most part of patients is not celiac, because celiac there is also genetic origin. But the real problem now is gluten sensitivity. Why now and not 30 years ago? Food, stress. You alterate the microbiota, you inflame the mucosa, and you have all these symptoms. So every time you find a patient with gluten sensitivity, please think of colostrum and noni. Normally, we use colostrum and noni, 1 sachet a day for long time, like 2-3 months. Every day, 1 sachet, it's oral soluble, and it's very easy for the patient to take it. Very interesting, just to share experience that I collect from all over the world, is the use of colostrum and noni in diarrhea. Very interesting, but in that case, you need to use more frequently the dietary supplement. That is not more 1 sachet per day, but 1 sachet 3-4 times per day, because you need to control diarrhea as soon as possible. Yeah?
Regarding to colostrum, does it make sense to take before food, after food?
After?
After food, before food?
No, it's completely, you can use before, after, or during.
Doesn't
Is not a medication, is a dietary supplement.
Morning, evening?
No, because it follows mechanisms that are not related to any chronobiology. For instance, when you use probiotics, maybe it's better to take them 30 minutes before meal in order to have the right pH, not to kill the bacteria. But this is completely another thing. So really it's very, very easy to use when your patient wants. No problem, really.
Can you get it without sucrose and sorbitol?
Excuse me?
Can you get this medication without sucrose and sorbitol?
Yes. Now the new production is with stevia. So no problem from that side. Yeah, we take it. Yeah, that was actually it was more a psychological problem because the quantity was completely not influenced. But the most part of people ask us to change, so we prefer to use stevia. Yeah. So the new new production, I mean, since 1 year more or less. All right, so this is what I wanted to share with you in order to stress some concept about systems, cells, and blah, blah, blah.